Is my screen visible?
GG.
Yes.
So we are live, I think. Dr. Vaishali?
Yes.
Yes.
Okay. Good afternoon, everyone, and a very warm welcome in today's Pink War webinar, which is a breast cancer screening initiative which has been taken by Dr. Arun. And in the basically, this is a collaboration of Max Hospital Healthcare and as well as the Delhi Gynae Forum. And today we are basically going to discuss about the various aspects of the screening of breast cancer. And this has been brought to us by none other than Dr. Sharda Jain ma'am, who has brought this Pink War initiative to each and every forum member of Delhi Gynecologist Forum, so that each and every gynecologist can be basically updated with the knowledge of the newer technologies, newer methodologies which is available to us. And we have with us Dr. Arun Kumar Goyal, who is the basically his brainchild is Pink War initiative. He is Senior Director of Surgical Oncology in Max Hospital, Vaishali. He's trained from All India Institute of Medical Sciences and Institute of Rotary Cancer Hospital, AIMS. He's been in practice for 25 years and he has more than 75 publications in national and international journals to his credit. We have with us as faculty Dr. Dinesh Singh. He's a Senior Director, Radiation Oncology. He is associated with Max Hospital, Vaishali, and is trained at Tata Memorial Hospital and in New York. He's got multiple publications in national and international journal. We have with us Dr. Vaishali Jhamre. She's a Senior Consultant and Unit Head of Breast Surgery in Rajiv Gandhi Cancer Hospital, Delhi. She's trained in breast oncology at Cardiff School of Medicine, Wales, UK, and special interest in oncoplastic breast surgery. Dr. Prekshi Chaudhary, she is Senior Consultant Radiation Oncology associated with Max Hospital, Vaishali. She has a special interest in breast and gynae oncology. And we have experts from Delhi Gynae Forum, Dr. Meenakshi Ahuja. She is the Director of Fortis Lafem, a cosmetic gynecologist, is President of Indian Menopause Society, and is presently Academic Secretary of Delhi Gynae Forum. And we have Dr. Leena Sridhar with us. Ma'am, I think will be joining us soon. Ma'am is a Senior Consultant at Manipal Hospital, Dwarka, and is Head of Department of Academics and Research of the hospital. She is alumni of Madan Azad Medical College. She is presently Secretary of Delhi Gynae Forum, Dwarka, and a co-chairperson of Delhi Gynae Forum Medical Legal Cell. And is an executive member of Multidisciplinary Committee, AOGD. And we have with us Dr. Shashilata Kabra Maheshwari. She is Senior Specialist in DDU Hospital in Delhi and is a Lakshya Nodal Officer. And Dr. Shashilata Kabra has organized many workshops and is really keen for postpartum hemorrhage. She is an NB faculty and a resource person and a recipient of Wonder Foxy Award. And we have with us Dr. Uma Vaidyanathan. Dr. Uma is a Senior Consultant for Tish Shalimar Bagh. She is Secretary of Delhi Gynae Forum North and Member QI Committee, AOGD. We have with us Dr. Manalini Mani. She is Head of the Department of Ops and Gynae Group, Govind Singh Hospital in Delhi. She was past President of Delhi Gynae Forum, Southwest. So we have an esteemed faculty and experts from the Delhi Gynae Forum with us in this gathering. And I hand over my mic to Dr. Sharda Jain ma'am for her address. After that, we will be going to Dr. Arun Goyal and we'll be following with the academic program.
Thank you, Dr. Meenakshi. And I think, the full credit goes to you and Dr. Goyal for organizing them repeatedly. Now, why are we organizing breast cancer awareness? We all know that the incidence of breast cancer in this country is that, we see almost 1.25 lakhs cases, new cases. And of these, 50 to 60% cases come late, which is bothersome because once we see them late, 50% we lose. While that's not so as far as the developed world is concerned, there the cases are picked up early and they have a better advantage as far as the survival is concerned. I feel, nearly 1/4 or 1/5 cases only have access to the best medical care as far as this country is concerned. And they have no formalized access to diagnostics and the treatment. You'll be surprised to know that more than a dozen cases of breast cancer have been picked up in gynecologists. So that, Dr. Goyal, brings us to another thing, that there is a lack of awareness about the disease and lack of awareness how to pick up early among the gynecologists. Leave aside, that once they are empowered, they will take it to the community and they will create awareness for the public, and they will take it to the grassroots level as per public awareness is concerned. Something need to be done. Every year from the 1st to 8th, I see to it, that we arrange mammography at peanuts price. Then also, I can definitely tell you about the East Delhi, that only 15 mammography have been done. We have a large number as far as the women doctors are concerned, but only 15 mammography have been done. This includes lady doctors, plus we have one thing is called WOW India, that is well-being of a woman, who are non-doctors. They have gone more. The doctors have availed these particular facilities less. So something need to be updated. And I think, we did MBBS long time back. We are not updated. And, a lot of water has flown under the river. And that is why there is a lack of expertise and technology. Something has to be done about, how to create it. जब भी इस तरह का कैंसर डिटेक्शन प्रोग्राम करते हैं तो उनको बस एक ही भय खाता आता है, अगर पॉजिटिव आ गया तो क्या करेंगे? अरे टेस्ट तो कराओ, पॉजिटिव आएगा तो देखेंगे, अच्छे लोग बैठे हैं ना यहाँ पर. So this is with this particular thing in mind. I'm at the crossroad. I do not know which way to go. So I think Dr. Goyal is definitely going to guide me how our gynecologists updated, so their disease is not picked up. We can't prevent it, but at least their disease is not picked up late. So this is what I need your cooperation, and we are ready to see that how we need to empower ourselves. There's a breast committee at the national level. There's a breast committee for every association, this thing. But what are we really doing it? I'm not too sure about it. We have Dr. Mani with us. Dr. Mani has taken over as the chairman of the breast committee of the, as far the Delhi is concerned. Dr. Meenakshi Ahuja is going to be the secretary of that particular committee. So a whole lot of members who are, you're going to see them, the expert, they are going to work hard, but they require direction from you. Sir, over to you.
Very good afternoon and a warm welcome to all the faculty and all the delegates. Before I start anything else, I must express my heartfelt gratitude and sincere thanks to both Dr. Sharda Jain and Dr. Meenakshi Sharma. When I shared this idea with Dr. Sharda Jain a few months ago, the positive response that I got, and with her own initiative, she has allowed us to organize these events in a virtual mode with all the branches of Delhi Gynecologist Forum on individual basis. And in addition to that, when I talked to her that we are going to have International Women's Day, so that may be an opportunity to do again. So I asked her to organize it at the whole state level. And she's always been so positive and very clear in actually what is the intention or purpose of, I think it cannot be expressed better than this. While the field of breast cancer, let us say it is not directly the domain of the gynecologist, but I think they are in a critical position to make a very positive influence. We have seen that majority of breast cancer patients or women who have breast symptoms, whether it is cancer or non-cancer, but breast symptoms, they often go to their gynecologist first. And then they receive guidance about whether they should have investigation, they should consult somebody else, they should take some medicines. So this is an opportunity where a clear concept of what needs to be done, so that we do not have any delay in a possible cancer. We do not say that every woman comes with cancer, but even if there is 1 out of 10 or 1 out of 20, we should not have any delay. And that is the whole purpose of this exercise. And Dr. Meenakshi has worked hard in organizing all the events, making WhatsApp groups, sharing messages, the event schedules and all. And so my heartfelt thanks to both of you, ma'am, first, and then for every team member from the Delhi Gynecologist Forum for taking part in this event. And again, I would express my sincere thanks to my colleagues, Dr. Dinesh, Dr. Vaishali, Dr. Prekshi, who have always been there in the planning of this activity, in preparing the presentations, in delivering, and they are always ready. And we are always there, ma'am. Anytime we need to organize the events, the virtual format gives us the flexibility. If we have 10 people or 20 people, if we have to do it every week, we are ready. Always. So you just tell us that you need to do this, we will do it. Now just we'll show one slide, and then so we have called it the Pink War, pink being the universal color for breast cancer. It's the activity which is basically under the banner of Max Healthcare, and we have an NGO called Indian Anti-Cancer Trust, which is constantly involved in supporting this activity. While we were planning this initiative, so me and Dr. Vaishali and Dr. Prekshi and Dr. Dinesh underwent some training from UICC. UICC runs a project called Project ECHO. So they guide us about how to plan these activities, and which I would say has helped us in planning and executing this activity. So I must express my heartfelt gratitude for them also. And as Dr. Sharda Jain ma'am has said, that breast cancer is the commonest cancer. The problem of advanced stage, delay, and poor outcomes in India is something we are going to focus on in the detailed presentations. But before we go to the detailed presentations, I would like to hand over the mic to Dr. Vaishali Zambre for taking over the proceedings of the event and organize the flow. Dr. Vaishali, please.
Yeah, thank you, sir. And a very warm welcome to all of you on this beautiful afternoon. And once again, I would say a happy International Women's Day to all of you. My greetings to the dignitaries of Delhi Gynae Forum, as well as Dr. Sharda Jain. So before we begin with the talks, we are going to have an online poll. We'll have four to five simple questions, which probably we'll be discussing later during the talks as well as during the Q&A session. And after the poll, we'll begin with the talks. We're going to have four small talks. One will be by Dr. Arun Goel, who will introduce us to the concept of what is the problem associated with delay in diagnosis of breast cancer and what are the problems we face in our day-to-day clinical practice. His talk will be followed by Dr. Prekshi Chaudhary, who is going to talk to us about the clinical signs and symptoms of breast cancer and where we should keep our index of suspicion high. I will be talking about the best way of diagnosing breast cancer so that we do not miss any lady with breast cancer. And Dr. Dinesh Singh sir will take us through the management aspects of breast cancer. After the talks, we will have a question and answer session, and later on the Delhi Gynae Forum experts will give their comments. So to begin with, I will invite Dr. Prekshi Chaudhary for the online poll. Over to you, Prekshi.
Thank you, ma'am. Good afternoon, everyone, and happy Women's Day to all of us. So now we'll be starting with the polls. We have 5 questions in the poll. First of all, we'll display the question, and then on the next slide, there'll be an option to choose. You can choose one of the options. Mr. Vinod, can you please share the slides? So this is the first question. In a 40 years lady who present with a breast lump, we need a pathological testing. So which pathology testing will you advise to her? A is FNAC, B, core needle biopsy, C, ultrasound guided core needle biopsy, or D, incisional or excisional biopsy. 40 years lady with lump. Please you release the poll, Mr. Vinod. Yeah, so
the poll has been launched. So I request everybody to please choose the appropriate option and submit.
So every question is 30 seconds, and in some questions you can even choose more than one options wherever you find it correct. Ma'am, please you click on the polls. Dr. Manju, ma'am, please click on the polls.
So Dr. Preksha, you got the result if you can.
Yeah. So 68% have chosen for ultrasound guided core needle biopsy. So now we move on to the next question. Question number 2. The most common presenting symptom of breast cancer. Is it painless lump in the breast, painful lump in the breast, nipple retraction, or nipple discharge? Please release. Yeah. So now you can see the options. You have to choose one of the. So I request everybody to please participate in the polls. These questions are just to reiterate and repurpose various important features, various important things which we have to focus on. So a painless lump in the breast has been chosen by 92% of the participants. Next question, please. Which type of nipple discharge raises a doubt of malignancy? Watery or serous discharge, milky discharge, dirty greenish discharge, or blood-stained discharge?
There can be more than one answers.
This could be a clue in this question. Next, please. So everybody, 100% of them have gone for blood-stained discharge. Moving on to question number 4. A 60 years lady presented with 1-year history of painless lump in the right breast. There was a 2 by 2 centimeter mobile firm lump in the right breast. Axilla was clear. So what is the first diagnosis which comes to your mind in this case? 60 years lady, fibroadenoma, fibroadenosis, CA breast, or breast tuberculosis? So carcinoma breast has been chosen by 45%. 41% have gone for fibroadenoma. Next, please. A 40 years lady with left-sided breast lump underwent X-ray mammography. The report came out to be PIRADS 0 in both the breasts. Now, what will be the next step? You'll reassure the patient, advise reassessment after 3 months, advise additional imaging, for example, ultrasound, or talk to the radiologist and seek clarification about the report. BI-RADS 0. %67 have gone for additional imaging in the form of ultrasound, etc. So here we are done with the polls. Now we'll start with sessions. Thank you, Mr. Vinod, for the polls. I now request Dr. Arun Goyal, sir, to please initiate the sessions.
Thank you, Dr. Prikshi. Coming back to the formal presentations. So, as a surgical oncologist who deals with breast cancer on a regular basis, this is one of the common presentations. So we have a 55-year-old lady. She had symptoms for 5 weeks, 35 days, which was started with pain. Clinically, on examination, there was nipple retraction, there was edema of the skin of the orange, there was the ill-defined lump, axillary lymphadenopathy. This patient shared her complaints with the family after 20 days, went to the family physician, had mammography and ultrasound, and then came to us. On the other extreme, this is a woman which I saw recently. The lady had symptoms for 2 years and was in this stage when she came to us. One of the papers which she brought with us kept a possibility of a breast abscess. Now, these are definitely, I would say, while the first one is not as late, but even then it is later than what we would want it to be. So now realizing what is the issue of breast cancer. So one, that breast cancer incidence. So we have data available from Globocan 2020, which is the latest database available, and it has become the #1 cancer all over the world. Between men and women, it is the commonest cancer. Nearly 22 lakh plus cases every year, which is about 12% of all the cancers in the world. When it comes to India, as per Globocan 2020, the figure is about 1,78,000 and the proportion is higher. Nearly 14% of cancer cases in India are breast cancer in women. Deaths due to breast cancer, so globally about 6,84,000 or 85,000, which is about 7% of all cancer deaths. But in India, breast cancer deaths are 90,000 plus, and they are nearly 11% of all cancer deaths. So breast cancer deaths are more important in India as a proportion of cancer deaths. So coming to this difference between the death rates globally, so we see what is the death rate of breast cancer globally. So globally, the death rate of breast cancer is about 30%, but in India, the breast cancer mortality is higher. It is about 51%. So in India, more than half of the breast cancer patients die of disease. There is another figure which we can look at, which is the 5-year survival data according to the extent of disease. This is from the SEER database in USA, which is a large database. And in this database, if the disease is localized to the breast, 99% patients have 5-year survival and beyond. When there is involvement of regional nodes, the survival figures is about 85% at 5 years and beyond. When there is distant metastasis, the figure is 29%. When we come to India, for stage 1, which is disease localized to the breast, the 5-year figures are around 90%. For stage 2, they are around 78%. For stage 3, 56%, and stage 4, 22%. So comparing, say, in relation to the extent of disease, the figures in India are quite reasonable. They are fairly comparable, just a difference of few percentage points. So stage for stage, Indian patients do reasonably well. So what else could be there? So when we look at the distribution of disease stage, so this is the global data, 63% are having localized cancer, which is confined to the breast. Nearly 30% have cancer, which is going to the regional nodes. Only 6% have metastasis and presentation. In contrast, in India, only 30% are localized and 60% have spread to the regional nodes. So these two figures actually reversed. Local was 60% plus globally, but it is only 30% in India, and regional, which was 30% globally, is 60% in India, a gross difference. So why do Indian patients present with more advanced disease? So one of the things is that in India, we do not have population-based screening. But again, I am not suggesting that we need population-based screening in India or India is ready for population-based screening. No, we are still not ready for population-based screening. The other major component is delay, and that is what is the focus of this whole activity today. Now, when we come to delay, so delay can happen in all parts of the patient's journey. There can be a delay in presentation, there can be a delay in diagnosis, and there can be a delay in treatment. So what are the facts and figures about delay? So we have carried out a study at Max Vaishali from January 18 to January 21, nearly 330 patients. The mean delay was 7 months, 6.6 months. So on an average, every patient spent 6.6 months before they came to Max Vaishali. So some spent less, but many spent more. The maximum delay in our study was 96 months or 8 years. And a delay of more than 1 month from the onset of symptoms were present in 70% of cases. So 3 out of 4 cases had a delay of more than 1 month from the onset of symptom. We analyzed the delay in terms of its components. So it was basically compared in 2 parts. Total delay was divided into patient delay and system delay. Patient delay is from the time that the patient notices the first symptom to the time they come to any doctor. And the system delay is from the time the patient comes to a doctor, any doctor, to the time they reached Max Vaishali. So we found that the patient delay was 3.62 months, but the system delay was no less. It was around 3.1 months. So more than 3 months of system delay happened from the time that the patient went to the first doctor. And again, by the time the patient came to Max Vaishali, the system delay is not over. After they come to Max Vaishali, also they are spending time in investigations and treatments. So the total system delay by the time they go for treatment would actually increase. So why is this delay occurring? When we talk about the patient interval delay, there are factors like lack of awareness, fear of diagnosis is a major factor. There are many patients who have financial issues and they are not able to go for medical consultation. A lot of patients have inertia, so unless they have troublesome symptoms, just a painless lump, and they ignore it. Then there are others. So for example, recently we had the COVID pandemic that has been responsible for delay. And sometimes the patient uses that excuse for delay when there may be other reasons also. So when we come to the system interval after the patient has seen the first doctor, there can be patient factors in this interval also. So some patients do not follow advice, do not undergo the advised investigations. Sometimes they go for alternative therapy. But then we also have this component of system factors. So what are the system factors? So system factors would pertain to suspecting cancer, diagnosing cancer, communication. This is something which is important. So we can think about cancer, a possibility. If we don't think, then we will not advise appropriate investigations. We may be thinking about cancer, but we may not advise the right investigative sequence. Or sometimes we may advise the right investigations, but we do not communicate properly to the patients, so they do not understand the importance of what is being advised. So can we do something? Definitely we can. But what then each of us needs to think is, can I do something? So ultimately, when each of us makes an effort together, we can make a lot of difference to this. So the message I am going to end with is something which will be repeated by my colleagues also, and which I believe should be taken to heart by all of you, is think of cancer whenever you see a breast lump or other breast-related symptoms. It doesn't mean that every lady has cancer, but we should think. And once we think of that cancer, we should investigate to either confirm a diagnosis of cancer or to make sure that there is no cancer. And it can be said in one phrase, be sure before you reassure. Thank you. So here I would end my presentation, and I would ask Dr. Prikshi Chaudhary to take over and talk about the common presenting symptoms of breast cancer.
Thank you, sir. So, is my screen visible?
Yes, yes.
So, the stage has been well set, and by now we know the magnitude of breast cancer, the global and national burden of the disease, how and why we are different from the Western world, and what are the factors which lead to delay in this diagnosis. So to avoid this delay, we have to be a little bit more cautious. We have to have a high index of suspicion. And what are those factors on which we should focus more? What are the risk factors for the occurrence of breast cancer? The first and foremost risk factor for the development of breast cancer is female gender. So being a female itself puts her at a higher risk. Although this disease is much more common in females, but it occurs in males too. The ratio is 100:1. Apart from the female gender, another most important risk factor is increasing age. The risk of breast cancer increases with increasing age. In this slide, we can see various stages in the lifetime of a female, from a young toddler to an old lady. So there is a subset of female population which is at negligible risk, and there is another group which is at substantial risk. We know that the risk of breast cancer increases after the age of 40 years, 40 to 45 years, and majority of the cases are diagnosed after that. However, these days, young ladies in their 20s and 30s are also being diagnosed with breast cancer. And these young females are usually found to have an aggressive histology, which are usually diagnosed in locally advanced stages. So any opportunity to diagnose these young females in an early stage should never be missed, and we should be a bit cautious. So any lady, if she's presenting with the breast lump or breast-related symptoms and she's more than 20 years, so keep cancer in mind. Yes, this is not the most common diagnosis in 20s and 30s, but at least we should think of cancer and she should be evaluated and investigated further. On the other hand, if a lady who is more than 50 years of age and is presenting with breast-related symptoms, then the first diagnosis which should come to our mind is breast cancer until proven otherwise. So any lady who is more than 50 years of age presenting with breast-related symptoms, this was a question in our polls too. So please consider it cancer unless proven otherwise. Now let us have a look at the age distribution of breast cancer cases. We start with US. So in this slide, we can this data has been taken from SEER database USA. So we can make out that majority of the cases are diagnosed after the age of 45 years, and the peak ages being 55 to 75 years. We can also see that around 10% of the cases are diagnosed even before 45 years. So here we can see that young females are also being diagnosed with breast cancer. This is the data of India. This is our hospital data. We can make out that majority of the cases are diagnosed after the age of 45. Yes, it is same. However, the peak decades of presentation, they have shifted to 1 decade earlier. That is, here now we can see the majority of the cases are seen in 45 to 65 years of age. And around 20% of the cases are being diagnosed before the age of 45 years. In US, around 10% of the cases are diagnosed before the age of 45. In India, around 20% cases are seen. So we are seeing more number of young patients. These ladies, they present to OPD with a gamut of clinical features. It can be either a breast lump, which is seen in majority of the cases, 85 to 90% of them present with a breast lump. She can also come with nipple related symptoms, like it can be inversion of nipple, which is of recent onset, any nipple discharge, or in extreme cases, it can be destruction of the nipple. Skin-related changes are also seen in some cases. Then there can be changes in the shape and size of the breast. Sometimes a lady may present with a lump in the axilla without any noticeable abnormality in the breast. All these cases, all these symptoms are seen in a bit locally advanced stage. However, in early stages, the lady may not have any significant symptoms. She might just present with an asymmetry of the breast, which is of recent onset. So like we saw this lady in OPD, she just had a discomfort in her right breast. On inspection, there was no abnormality and both the breasts are symmetrical. However, on a careful palpation, there was an ill-defined lump in the upper outer quadrant of right breast. So this is just to emphasize the importance of a careful inspection and palpation after taking a proper history. So breast lump is the most common we have seen. Yes, in 85 to 90% of the cases, the patient presents with a breast lump. To begin with, this lump is painless. So majority of the breast lumps are painless in case of malignancy. When they increase in size, they may involve the adjacent structures or neural structures, and they can be associated with pain. However, so painless lump or painful lump, it does not rule out cancer. Yes, majority are painless, but if it is associated with pain, even then it can be malignant. Some ladies, they give a history of the presence of breast lump for 1 year or even more than that. And in some cases, they have a history, they have a very short history of just 1 month, 1 week, or 1 day. So some cancers are slow growing and they have a very long history. It might take 1 or 2 years for the patient to present to the clinician. And in some cancers, they are very aggressively growing. They grow fast and they have a very short history. Another thing is that the lady might have noticed a pre-existing lump. Does not mean that the duration of the lump is 1 month or 1 week or 1 day. It might be a pre-existing lump, but the lady might not have appreciated it. So a long history or a short history does not refute or confirm malignancy. It can be either ways. Many times they give a history of minor trauma and they attribute the presence of a swelling or a lump to the preceding trauma. However, trauma might just have brought the attention of the lady towards a pre-existing lump, and the history of trauma definitely does not rule out malignancy. Then young ladies, when they present with breast lump, fibroadenoma is the most common diagnosis, yes. But as we have seen the facts and figures that even 20s and 30s, a female can diagnose with breast cancer. So each and every lump in a young patient is not fibroadenoma. So if she's presenting with a breast-related symptoms or a breast lump, then she should be carefully investigated to rule out malignancy. A positive family history definitely puts the patient at higher risk, and the number of first-degree relatives, second-degree relatives. So all these things, yes, there is a high risk. Around 10 to 15% of the newly diagnosed cases, they have a positive family history. However, what about 85 to 90% of them? They do not have any positive family history. So a positive family history puts her at a higher risk, but a negative one does not rule out malignancy. Another important symptom with regards to breast is nipple discharge. In reproductive age group, many ladies may have nipple discharge, and each and every nipple discharge is not associated with malignancy. So what kind of discharge should raise our suspicion? It is usually spontaneous, comes out without pressing, may be watery, serous, serosanguinous, or blood stained. And it comes out of a single duct and it is unilateral. Any such type of discharge, whenever noticed, such patient should be carefully evaluated further. Pregnancy in breast cancer breast cancer in pregnancy is rare, but it is real. So breast cancer is the second most common cancer which is diagnosed in a pregnant female after cervical cancer, around 2 to 3%, and this breast cancer in pregnancy makes around 2 to 3% of total cases of breast cancer. So there are, yes, we all know there are some physiological changes in breast during pregnancy, the breast becoming engorged, and it is very difficult to appreciate any lump for the lady as well as for the clinician. So any lady presenting, pregnant female is presenting to the OPD with breast related symptoms, she should be carefully examined. And if we find any lump, then ultrasound is a very safe and effective method to diagnose any such lump. And if we find a lump on ultrasound, then biopsy can be safely carried out in such cases. So whenever we see a breast lump, we have to rule out cancer, whether it is painful or it is painless, whether there is a positive family history or there is a negative family history, whether there is a long-standing history, whether it is a short-standing history. In each and every breast lump, we have to evaluate the patient. We have to investigate her further. We have to be sure ourselves before we reassure the patient. So this is my concluding slide. Thank you. Now I would like to invite Dr. Vaishali Zambre to take the journey forward. Over to you, ma'am.
Thanks, Dr. Prekshi. So taking the baton forward from Dr. Prekshi, I hope my slides are visible.
Yes, ma'am.
Yes, okay. So we all know that breast. So Dr. Prekshi has taken us through the various, important symptoms of breast cancer. And for all these women who present with breast-related symptoms, there are three important things which we have to actually remember to take the lady to a logical conclusion. The first thing is triple assessment. Number 2 is triple assessment, and number 3 is triple assessment. So I might have sounded very dramatic here when I said triple assessment, triple assessment, triple assessment. But let me tell you that triple assessment is the fundamental tool for diagnosis of any patient who comes to us with breast-related symptoms, so as to not to miss any lady with breast cancer. So what are the three important aspects of triple assessment? One is clinical assessment, which Dr. Prekshi has already elaborated upon. Then the other important thing is imaging and pathology. So that after the triple assessment, after all these components are carried out, we come to a definitive diagnosis in majority of the patient, whether the problem at hand is malignant or benign. So detailed history and thorough clinical examination cannot be overemphasized here. When we think about examination of a patient with breast-related symptoms, it has to be done in a proper systematic manner in lying down as well as in sitting position. Examination of both the breast has to be carried out, as well as examination of the draining lymph node areas, that is the axillary areas as well as the supraclavicular areas. Then the next important step is imaging. Appropriate imaging is a very, very important fundamental aspect of triple assessment. And it is critical that we have to look for BIRAD reporting. If it is not reported, then it is a responsibility to request the radiologist to, give a BIRAD number to that particular imaging, whether it is a mammogram or an ultrasound or MRI. We need an expert radiologist, and high quality imaging is very, very critical to diagnose breast related symptoms. So in majority of the patients, ultrasound and mammography form the basic imaging tool. We generally prefer ultrasound for breast related symptoms seen in young women, and mammography is used for as a first modality of imaging for women who present to us with breast related symptoms after the age of 40. However, ultrasound and mammography, they complement each other. And even in young women, if there are very suspicious clinical findings, even irrespective of the patient's age, mammography also needs to be done, because sometimes we need to see whether the patient has suspicious microcalcifications, which will tell us about the area of ductal carcinoma in situ, which may not be seen on ultrasound. MRI is very rarely required, and there are very specific indications for doing MRI in breast related symptoms. And an ideal mammogram should look like this. There are two views, ideally craniocaudal and MLO views, that is medial lateral oblique. Occasionally, we might need some other imaging views like lateral view or spot compression or magnification views. The importance of a proper exposure, which includes all the areas of the breast, is very important. And the person who is actually the technician who is performing a mammogram on a lady should be trained enough so that all the areas are properly covered. And a little bit about breast density. As I mentioned here, that mammography is the modality of imaging which is preferred for women over the age of 40 years. That is so because in young women, the breasts are extremely dense. So in a dense breast, it is very difficult to locate or identify a suspicious abnormality. As a woman grows older towards her menopausal age, the breast density goes down. So as you can see here, that on the right hand side, there is extremely dense breast of a young woman, and this is a heterogeneously dense breast which is labeled as ACRC. And as the lady grows older, it becomes entirely fatty. And in postmenopausal women or women who are older than 40-45 years, if the breasts are fatty, it is easy to locate any abnormal area. Then a little bit about BIRADs. We have mentioned about BIRAD system. This is way by which the breast imaging actually is reported. So I'll like to draw your attention to two important BIRADs categories, that is BIRAD 4 and 5. BIRAD 4 is actually subdivided into 4A, 4B and 4C. Based on the level of suspicion, it can be say 2 to 94%, and BIRAD 5 is actually highly suspicious. That is more than 95% of suspicion of harboring a malignancy in that. And in these two categories, BIRAD 4 and 5, tissue sampling or pathological investigation is a must. So biopsy is indicated, or it is mandatory for a lady who has BIRAD reporting of BIRAD 4 or 5. Then I would also like to draw your attention to BIRAD 0. There was a question in the poll also. So many times it is confused to be a normal imaging. No, BIRAD 0 does not mean a normal imaging. It just means that the radiologist needs an additional imaging to give a proper BIRAD category to that particular imaging. Now, when we come to the next in the triple assessment, that is pathological assessment of any suspicious area. So we have been actually advising fine needle aspiration cytology or FNAC for many years. However, there are some shortcomings of FNAC when it comes to breast cancer diagnosis. It needs an expert cytopathologist to interpret the FNAC slides, and many a times because of inadequate samples, there could be a false negative or falsely positive fine needle aspiration cytology result. As a result, now we have actually moved over to core needle biopsy, which is considered to be the gold standard for diagnosis of any suspicious breast-related symptom and sign. So, to obtain core needle biopsy, usually a thicker needle is preferred. A 14 to 16 gauge needle should be preferred, and at least 4 cores should be obtained. 4 or more cores should be obtained. And the best or the ideal way of doing a core needle biopsy is to be image guided. That is the most preferred way or most easy way of doing a core needle biopsy is ultrasound. Ultrasound guided biopsy is generally preferred in many women. Only when the ultrasound is not able to locate that abnormality, sometimes we might need to do MR guided or stereotactic, that is mammography guided biopsy. It is when we compare it with FNAC, core needle biopsy is much more sensitive, specific, as well as accurate. False positives are never seen, and false negatives are also very negligible. And we can also diagnose in situ carcinoma in core needle biopsy, which is not possible on FNAC. And we can also do immunohistochemical markers so as to understand the biological profile of that particular breast cancer. So after the result of triple negative assessment, we in majority of the patients can come to a clear-cut understanding whether the problem with which the patient has come to us is whether benign problem or something which we need to intervene further. However, in some 5 to 10% of the patients, there can be a discordance. So we have to be aware of this discordance. So there can be a clinical and radiological discordance. That means that a clinician is able to see something suspicious or feel something suspicious. However, the radiologist is not able to see that in that imaging. So the problem of this clinical radiological suspicion could be either dense breast, as I had shown you previously, or the imaging has not been done properly, or the radiologist has either missed or misinterpreted the findings. So if we say this, in this lady, there was a suspicious palpable lump. However, although she was 45 years of age, her breasts were very, very dense, and we cannot see any abnormality on right side here. However, because of the clinical suspicion, an MRI was advised, and as you can see here, the clinical suspicious finding was very well seen on MRI. And the core needle biopsy then confirmed it to be a malignancy. So we have to actually be aware that irrespective of the mammographic findings, if there is any suspicious clinical finding, then that needs to be further evaluated. So whether we need an additional MR or ultrasound, that has to be kept in mind. Then there can be clinico-radiological versus pathological discordance. That means that the clinician is able to feel something suspicious. The radiologist also agrees that there is something suspicious on imaging. However, the pathologist is not able to see anything suspicious in the specimen which has been submitted to her or him. So it could be again a problem because of suboptimal sampling, or it might be that the sample was not processed properly, or there could be a problem in interpretation of the result. An example of this is that this lady presented with a palpable abnormality that was also seen on her clearly seen on her imaging. You can see this on mammography as well as on ultrasound. However, the biopsy was performed without any imaging guidance, and as a result, the biopsy needle went somewhere else instead of targeting the lesion which was there, and as a result, it was reported as fibrocystic disease. However, because there was a clinical suspicion, then this lady underwent wide local excision of that disease, of that palpable abnormality, and it was reported as high-grade DCIS. So, to minimize this problem of discordance, it is important because it can lead to missing the diagnosis, and we have to be very, very mindful of this fact that if there is any suspicious finding, we have to we have to actually rely on our clinical judgment and take the patient to further investigation or advise further investigation so that we do not miss out on any cancer. And a dialogue between a clinician, a radiologist, as well as a pathologist is very, very important. We have to provide a very thorough clinical finding as well as the detailed history to both of these colleagues so that we don't miss and we all of us are on the same page. So at the end of my talk, I would like to conclude by reiterating the fact what my colleague Dr. Goyal and Dr. Prikshi has said, that whenever we come across any lady or any patient who presents with suspicious breast related symptom, we have to think of cancer, and that lady needs to be investigated further to confirm or to exclude cancer. And we have to be sure ourselves before we can reassure that lady that there is no cancer. So with this, I would like to stop my presentation and hand over the mic to Dr. Dinesh Singh. Over to you, sir.
Hello. Hello. Hello.
Yes.
Yeah, I think Dr. Dinesh just left.
Left.
Yeah.
He got disconnected.
Yeah, just disconnected.
Okay, we'll wait for a minute. I think he must be joining.
Okay.
I think meanwhile, I can only say that if there are any questions, please put them in the chat box, and then after the presentation of Dr. Dinesh, we can take we can go for discussions on it. Okay.
He is here, yeah.
Dr. Dinesh, your presentation.
Yeah, sorry for the glitch, it got disconnected. I'll just start sharing my screen. Is it visible now?
Yes.
Yes, sir. Yes.
So good evening once again. And as we have seen till now that there is a delay between the onset of symptoms and the onset of treatment. And as Dr. Goyal has told that the treatment stage by stage is almost same whether in India or into the Western world. For these patients and start their treatment timely. And when we talk about the treatment of breast cancer, then we are reminded of sunshine and rainbow. And sunshine, because the results are good stage by stage, the patients are getting cured and they are living for long life. Rainbow, because it is a complex treatment. There are so many modalities in the patient which have to account, and we have to tailor-made the treatment according to whether the patient is hormone positive or HER positive. So whenever we diagnose a patient and do a total staging workup of these patients, then we go on to the discussion to decide what treatment modality the patient should undergo. Some patients, they need to undergo surgery upfront. Some patients, they may need to undergo chemotherapy before surgery is taken up. And this decision is taken on all the biological parameters and the pathological and anatomical characters of that particular patient. We have seen that the long-term survival is increasing in breast cancer patients. And the next question that we ask is how can we increase quality of life of patients who are undergoing treatment, while on treatment, and also once they have completed treatment and they have been cured and they are maintaining good quality of life. For that, de-escalation is a very important thing. When we talk about the treatment of breast cancer, we have to maintain the same oncological principles for the cure of the patient, and also de-escalate the treatment so that we are de-escalating their morbidities as well. When we talk about the surgical modality, earlier it used to be total mastectomy for every patient regardless of the tumor size or any other factors. As we progressed, then the breast conservation surgery became the norm, in which only the tumor with safe margins and axillary dissection was done and the breast was conserved. This also dependent upon the tumor breast ratio. And in those patients in which this ratio is not favorable, then there are the oncoplastic breast conservation procedures are taken, in which these patients are able to retain the breast and get cured of cancer. And in those patients, even when in this is not favorable and they have to undergo a modified radical mastectomy, then there is an option of breast reconstruction. It can be done either in the same setting, or we can do it in a later treatment stage when we are completed with chemo and radiation. Axilla is a very important component of treatment of breast cancer. As we all know, the axillary nodes combine of level 1, 2, and 3 critical. In those patients in which clinical and radiologically the axillary nodes are negative, in them a sentinel lymph node biopsy procedure is carried out in the operation theater. And in those patients in which sentinel nodes are negative, we do not need to perform a axillary dissection. So it can be completed without completion, and in case if those nodes are positive, in those patients only axillary procedure is carried on. And future it is being investigated whether we can do away with any axillary procedures in some select patients. Then we come to the treatment using radiation, which are the primarily X-rays. Earlier it used to be a telecobalt machine, you can see here, and it was associated with lot of morbidity because of the scattering which occurs with this equipment. Next came the linear accelerators, in which the beam became very much focused, and we are called IMRT, or intensity modulated radiation, along with the image guidance. And in this also we are able to give simultaneously a higher dose to the tumor bed and a lower dose to the entire breast, with saving of the lung and the heart is possible in these things. And another technique which is brachytherapy. This is the equipment of brachytherapy, and the sources are inserted into the tumor bed after the surgery has been done, and in this we are able to give a very precise dose of radiation to the tumor bed. It is especially applicable in cases of APBI, or the accelerated partial breast irradiation, in a select group of patients which do not need radiation to the entire breast. Of treatment, it used to be earlier chest wall or the whole breast with regional nodal irradiations, but now more and more times in some favorable patients we are able to do partial breast irradiation, and the irradiation of axillary lymph nodes is largely done away with. Another thing is about the duration of treatment or number of visits. The hospital visits have to be made by the patient. In the past, it used to be 5 weeks plus boost 4 sittings if required. Presently, we are into an era in which 3 weeks treatment is required with a boost if required. And the future direction is coming towards just 5 days visits to the hospital for completing the radiation to the breast region. Next in line is chemotherapy. The systemic therapy comprising of chemotherapy, endocrine therapy in those patients in which hormone receptors are positive, ER or PR or both. HER2 targeted therapy in those patients in which HER2 target is positive. And now we are having a lot of other targets also available in breast cancer patients, which are used as and when they are required. Now, the quality of life for those patients who are undergoing systemic therapies, venous access is a major concern, in which a chemo port or a PICC line is used for continuous trouble-free access provided to the patient during the entire course of the chemotherapy. Growth factor support is taken up whenever required, so the patient doesn't land up into neutropenia or febrile neutropenia. To take care of hair loss, a cooling head cap can be used, which produces hypothermia to the scalp, and thus it reduces the hair loss of patients undergoing chemotherapy. Lymphedema is taken care of by the axilla, reducing the axillary dissection wherever possible and avoiding radiation to the axilla, and also promoting patients to keep on doing their regular shoulder and hand exercises to maintain the health. Bone health, primarily from the DEXA findings, vitamin D, and other support things, it's taken care of. वैसे भी many of these patients are post-menopausal, so bone health even otherwise becomes a major issue, and especially more so in those patients who are undergoing aromatase inhibitors as their hormone supplements. Various support groups are there in which the patient connect with each other and also with the other treating faculty, so that they can share their concerns and help each other. Told by Dr. Goyal also. Now we are looking a very good, if you look at the 9-year survival in T1, T2 node negative hormone receptor positive, we are looking of 9-year survival going beyond 90 years. So this is very encouraging, and we have to see that life is not over after breast cancer. Many patients are getting diagnosed with breast cancer in very early age, and these patients, once they are cured of breast cancer, they want to proceed further into their family life and having kids, and which is perfectly fine. So, in fact, a survival can bring a new life into this world. Pregnancy after breast is a real possibility for young women. As told by my previous speakers also, we have to think of cancer whenever we see a breast lump or any symptoms in the breast. We have to investigate either to confirm or to exclude the cancer. So we have to be very sure before we reassure the patients who are visiting us. Thank you very much.
I think we will be happy to take any questions if someone wants to either write in the chat box, or I think Dr. Goyal wants to answer this question which is there in the Q&A box. Sir, would you like to take
one question? There's one question in the chat box. Can we reassure the patient of a breast lump with clinical finding of fibroadenoma without ultrasound or FNAC?
Yeah, basically, when we think about a clinical diagnosis of fibroadenoma, so there are many things which should be considered. Age of the patient is one, duration of history, the clinical feel of the lump, size, shape, and mobility within the breast tissue. But usually nowadays, we recommend as a minimum an ultrasound assessment of the breast. So the purpose of ultrasound assessment of the breast is to sort of look at the internal characteristics also, if there are any cystic areas within it or not. Vascularity can also be assessed on ultrasound. If there are any other lesions in the same breast or the opposite breast. So even when a patient is not undergoing any specific treatment or biopsy, an ultrasound, I would say, is a minimum investigation today. So if clinical assessment, ultrasound, and all the other factors are in favor of it being a fibroadenoma, then we reassure the patient. But then there are certain things which we need to understand is that the major differential diagnosis for fibroadenoma can be a cystosarcoma phyllodes, because there can be a similar characteristic. So if the history is short, the size is slightly large, or if it is growing rapidly, then we may think of a possibility of a cystosarcoma phyllodes or a phyllodes tumor. And in such a case, a biopsy would be worthwhile to do before reassuring the patient. So a core needle biopsy also shows no suspicion of cystosarcoma, then we reassure the patient and follow up. And whenever we ask the patient to be on follow-up, we tell them, please do regular self-examination, keep a watch on the size of the lump. If the lump is increasing in size, then you come back. Do not sit at home while the lump is increasing in size.
And I would also like to add to what sir has said, that many times what happens is, especially there are certain type of cancers called as triple negative breast cancers, which might look like a fibroadenoma on mammography as well as on ultrasound. They are quite smooth, rounded. However, we have to keep that index of suspicion high, especially if the lump is recently noticed by a lady who is over the age of say 35 or 40 years, then it needs to be biopsied, because these type of cancers also can look like or mimic fibroadenoma on imaging. So we have to have that thing kept in mind, that they can look like fibroadenoma.
Sir, I have one question.
Yes.
Some people, some females have 3-4 fibroadenoma one side, 2-3 fibroadenomas multiple. So does it make any difference in our management, or does it make more prone for cancer?
So multiple fibroadenomas per se usually does not increase the risk of having cancer. But if if there are multiple such lumps, and if any one of them is growing, or if it is causing some cosmetic deformity in the breast, then yes, we do suggest that surgery can be done. And if the fibroadenomas are small, they are peripherally located, say up to the size of 3 centimeters, then sometimes vacuum assisted breast biopsy also can be done to take care of fibroadenomas. So it can be.
Is there any specific size of fibroadenoma above which we must have a biopsy, or that should be excised? Because I had seen, I think 2-3 days back, I had seen one patient. Almost half of the breast was involved in one large fibroadenoma. FNAC में भी fibroadenoma ही आ रहा था.
So it must be a giant fibroadenoma, which is commonly seen in young patients. So
yes, young ladies.
Yeah, so definitely that needs excision, because occasionally it can so happen that even on core needle biopsy, sometimes it can be a problem differentiating between whether it is just a fibroadenoma or a benign phyllodes tumor. So in these large tumors, definitely we recommend surgery.
So, Dr. Poonam, I think you mentioned FNAC. So again, I think we would like to repeat the message that today FNAC is not the investigation. As a rule, we should ask for core needle biopsy, and preferably ultrasound guided core needle biopsy.
And for patient who have cosmetic implants and all, in those patients, mammography is the best investigation, or ultrasound?
So it depends on what age. Are we one is age, and what are we trying to look for. If there is a clinical suspicion, even in the presence of implants, mammography can be done. There are special techniques for patients to undergo mammography with implants, so we can do both.
Or variants?
Yes.
Always in such cases, if we need additional investigation, say MRI may be a useful investigation to add in the presence of implants.
Sir, I think you should take the questionnaire again. So, and after that, your comment and the expert's comment should be there. I think they should definitely take a questionnaire again.
Kalpesh, can we have the poll questions done once again?
Yeah, just a second.
Dr. Prekshi, please go through it.
Yes, sir.
Hello. Yes, sir.
The poll questions, if we just want to repeat the same questions again.
Okay. Just result, or you want to take?
No. The questions and
Take the poll again.
Okay.
Polling again.
So, yeah, the first question was 40 years lady present with the breast lump. What will be the investigation of choice regarding histopathology? In this case, is it FNAC, core needle biopsy, or two-cut biopsy, ultrasound guided core needle biopsy, or incisional and excisional biopsy? So I hope everybody is able to choose an option. It was for 30 seconds only. So 80% have gone for ultrasound guided core needle biopsy. I'll be reading the questions very quickly because the poll will last for only 30 seconds. Next question, please. What is the most common presenting symptom of breast cancer? Painless lump, painful lump, nipple retraction, or nipple discharge? So 92% have gone for painless lump in the breast. Which type of nipple discharge raises a doubt of malignancy? Watery or serous discharge, milky discharge, dirty greenish discharge, or blood-stained discharge? So blood-stained discharge has been chosen by majority, 89% of them. A 60-year lady has a 1-year history of painless lump in the right breast. On examination, 2 by 2 centimeter mobile firm lump in right breast was there. No axillary lymphadenopathy. What is the most likely diagnosis? Kindly emphasize on the age. It is 60 years. So is it fibroadenoma, fibroadenosis, carcinoma of the breast, or breast tuberculosis? So carcinoma of the breast has been chosen by 81%. However, 20% have gone with fibroadenoma. Next, please. A 40-year lady with left-sided breast lump underwent X-ray mammography. Result was BI-RAD 0. What will you do now? Reassure the patient, reassessment after 3 months, advise additional imaging in the form of ultrasound, or talk to the radiologist and seek clarification about the report in BI-RAD 0. So an additional imaging has been chosen by 80%, around 80%. So we can close the poll now.
Yeah, thank you, Dr. Brekshi. And overall, I would say the results of the poll, even pre and post, have been quite encouraging compared to the responses we used to have when we started this series. So overall, just to stress again, core needle biopsy, preferably ultrasound guided, is the recommended approach. The reason for choosing ultrasound guidance is that for smaller lumps, ultrasound allows you to position the needle accurately in the lump. For larger lumps, sometimes there may be necrotic area or cystic area, which on a blind biopsy may fail to give a good result. So even in a large lump, ultrasound guidance is better. Painless lump, as has been highlighted, is the single most common presenting symptom of breast cancer. Does not mean that others cannot be the presenting symptoms, but about 80 to 90% have painless lump as a presenting symptom. Nipple discharge, it is either blood stain or watery or serous discharge, particularly single breast spontaneous. These are important combinations: single breast, spontaneous, and either watery or blood stained. 60-year lady, again, as Dr. Brachy had highlighted, women above 50, any breast lump, we should think of cancer unless proven otherwise. A recent onset lump in the woman age of 40. So even if it has been present for 1 year, 1.5 years, 2 years, does not mean. We have to think of cancer as the first possibility. BIRAT 0 is something, since we see a lot of mammography, this BIRAT system is a standardized system of reporting. We should insist on the radiologist to use a BIRAT category in reporting. If it is BIRAT 0, it does not mean that it is actually normal. It only means that it is not adequate imaging. So we need to either go back to the radiologist, talk to them, or advise additional imaging, which usually is an ultrasound to begin with, and later on, if required, we may need to go for MR mammography, spot compression cells, or anything else. But we cannot reassure the patient or ask them to wait and watch. So that is for the poll questions. But overall, I would say quite a positive improvement in the poll results. So is there anything else in the chat? Or,
I will ask Dr. Meenakshi Sharma to comment upon the pre and the post poll.
And pre and post both are increasing. Results have shown that we are really able to diagnose the patients of breast cancer early, and we will be able to advise them for a core needle biopsy in preference to FNAC, as FNAC does not, it leads to lots of false positive and negative. So core needle biopsy is the investigation of choice to diagnose breast cancer. And through this whole session, we in fact learn that earlier that we diagnose the breast cancer, better is the patient outcome. Stage 1 has a more than 90% survival. So no stone should be basically left unturned to diagnose breast cancer early. That can be done by self-breast examination, by triple assessment, with a referral to a special breast cancer specialist whenever we need to. So this is the main take-home points we have from the presentation. And there's one more question in the chat box by Dr. Ela.
And what he said was, be sure before you reassure.
Be sure before you reassure. That should be the tagline of the message. Dr. Ela wants to know about the younger patients who has recurrent big fibroadenomas. How do we deal with such patient? Young patient with large recurrent fibroadenoma.
Usually, fibroadenoma, if it is, excised properly, then it should not recur. So if it is recurring, that means that either it is something else, that it could be a phyllodes tumor, or that lady may have, a tendency of having a multiple fibroadenoma. So it is not that the excised fibroadenoma has recurred, she's developed a new fibroadenoma. So if there are multiple of them, then definitely, and if they're large, and leading to cosmetic deformity in the breast, then surgery is the way. And if it is not a fibroadenoma, then it has to be properly diagnosed. So a coronary biopsy has to be done. Appropriate imaging may be needed to see whether it is really a fibroadenoma, or if it is, we are not missing out on any phyllodes tumor. If it is a phyllodes tumor, then it has to be excised, obviously with appropriate margins, and that is how that lady needs to be managed.
Thank you.
I want to ask, madam, there are some patients on ultrasound, you will find 2-3 centimeter cyst, that is a simple cyst, just very little peripheral blood flow, and patient doesn't have any pain, nothing, not inflammatory. In those cases, what should be done?
So if
can we just aspirate the cyst and then leave it, or what to do?
So usually such multiple cysts can be seen in during menstrual phases, different phases of menstrual cycle. So if the lady is not symptomatic, if the, as Dr. Goyal has also answered that question, if the cysts are very thin walled, clear cyst without any, solid component within the cyst, then if the patient is asymptomatic, then we need not do anything. We just
size. What would be the size which we can ignore? 2-3 centimeters we can ignore.
So if it is a large, say 5 centimeters cyst, then obviously it will be visible as well as the patient will be, symptomatic. So 2-3 centimeter size, multiple cyst, if the patient is asymptomatic, clear cyst, no, the walls are not thick, there are no septations, there are no, solid components within, we can keep the patient as a follow-up.
So after this brainstorming session today, I move on to the expert comments from our expert gynecologist. We have with us Dr. Meenakshi Ahuja, ma'am. Would you like to go first?
I think it's been a really enlightening session.
Dr.
Uma is, yeah. Hello? Yeah, am I audible? Yeah. So, I think it's been a really enlightening session, and actually what I was told to talk about was breast examination, self-breast examination. So that's something that every woman should know. In fact, today in the OPD, I was teaching a patient and I realized that we all must have this motivation that in every single OPD, 2 patients at least, we must teach them how to do a breast self-examination. Right? So every woman over 20 needs to do a breast self-examination once a month, and the correct time to do it would be immediately after her periods. And if she's menopausal, then probably the first of every month. It's very simple when you explain to your patients, and that's what I'm going to just be saying. Because the clinical examination needs to be done by gynecologists once a year after 30, and of course the mammogram is later. So when we are doing an examination every month, the right time to do it is, like I said, immediately after your periods. And the way to do it is that you just take the palm and you will be taking the flat of the hand rather than the tips of the fingers or the palm of your hand. So it's done with this part. The right place to do it is in the bathroom. Normally one breast may be bigger than the other and one nipple may be above the other. So the way to do it is that making little circles with the palm or with the flat of your fingers, you'll be examining the entire breast, either in concentric circles from outwards, inwards, or from top to bottom, or from one side to the other, and feeling for any lumps. Remember that the right time to do it is immediately after the periods are done and with the flat of the fingers. So these are the 2 very important things. If any lump or mass is seen, you must go and see your gynecologist or your surgeon. The other thing is that after that, you must check the underarms also, all the 4 walls and in the center to see if there are any lymph nodes present. It's a very simple exercise. And as the soap glides over the breast when you're having a bath, that's the easiest place to do it. So I think the point here is that every single day of our OPD, we must teach 2 women how to do a breast self-examination. Thank you.
That's a very important tip, ma'am. Dr. Leena Sridhar, ma'am, can you please, please unmute yourself.
Yes. Thank you very much, Dr. Meenakshi. And I was just going very, closely hearing all, the various sessions, and it was really wonderful. And what struck me was something, although I have to be talking about the prevalence and the incidence of breast cancer, the one thing which, I think we should send it as a take-home message is only reassure the patient after being sure. I really like that statement because, we are practicing gynecologists, and 99.9%, I would say, the patient, the moment she has a lump, because the patient, breast cancer can only happen to, commonly happens in women. It can happen in men also. But when it happens, the first person the patient who goes to is the gynecologist. So I think it's imperative that we know for sure before we even reassure her. Because many times, when you tell them that, look, this is required, you need to do a true cut biopsy and ultrasound guided and all that, the first thing the patient tells us is, doctor, what do you think it is? And then, what happens is over a period of time, and I'm seeing so many of our experienced gynecologists on this platform, they always sort of assume that, okay, doctor, you've got so many years of experience. So in your experience, what do you think it is? So, the urgency, how to convey, the kind of communication we have to do, I think that is very, very important. Most of the time, when you tell them that, look, you've got to go ahead and get the ultrasound guided to cut biopsy, they say, oh, but it's been there, ek saal pehle bhi tha, they gave me this, they gave me that, it came down, now again it is. So basically they have come because, they want a kind of reassurance from us. They don't want us to go for further testing. So I think that this lecture, this series has been wonderful because it's an eye opener for everyone that let us not reassure the patient until we are 100% assured what are we dealing with. Because, and I was going through the statistics, breast cancer is steadily climbing at the rate of 0.5% per year. Our mortality statistics are falling down, but the incidence doesn't show any signs of, becoming less in the years to come. In fact, I got out some statistics that were really, I would say not just alarming, but quite an eye opener for us. At least I was not aware of that. That is what has been postulated by the American Cancer Society, is that by the year 2022, that is this year, about 2,87,850 new cases of invasive cancer will be diagnosed. And about 51,400 new cases of the ductal carcinoma in situ. And we could end up having about 49,200 women to die from breast cancer in the year 2022. These are global statistics. What is again worrisome is that in India, the maximum cases are in these metros, Delhi, Bangalore, Chennai, and they have found that the median, the incidence, the age group in which it is seen is the younger age group, 40, 50s, that age group, as compared to the West, where you get it more in the, post 60s. Now, that again is something very worrisome. And definitely the incident rates have been increasing by about 0.5% per year. So now, we used to always, not that cervical cancer has gone, but, steadily breast cancer is trying to take up that, number one position to say. I mean, there's already an urban-rural divide which has been seen. And now with the margins between the urban areas and the rural areas getting diffused, we are definitely going to be seeing a lot more of breast cancer. So we as gynecologists, I think being the first persons who deal with patients need to be a lot more aware. And I just like this term very much because everything can be summed up in just one word, that be absolutely sure before you reassure. I like that statement very much.
Thank you so much, ma'am. Dr. Shashilata, ma'am, would you like to comment on the presentation? Yeah.
So first of all, congratulations for conducting such a wonderful webinar. And you know that breast is more and more becoming a gynecological organ, and the patient gets opportunity to come to obstetrician or gynecologist first. So definitely it is our duty to make awareness about breast disease and to help in diagnosis. So I have to talk about triple test, and as Dr. Vaishali Jamre has said, triple test, and triple test. Exactly. It is said thrice, and it is the diagnostic modality for any new lump in the breast. So what is this triple test? It is a sequence of tests which is to be done for diagnosing a new breast lump. And the first thing is a clinical examination. And that clinical examination is to be done by a medical personnel, a doctor, and it will be a thorough clinical examination of both the breast, nipples, all the quadrants, armpit up to the clavicle. So this is very important, and they will also look for nipple discharge or any other abnormal discharge. And the second test is imaging modality. So the imaging modality is mainly a mammography, which is a low dose X-ray, and second is ultrasonography. Now for the ultrasonography, age group is very important. In more than 35 years, we prefer mammography, and in less than 35 years, we prefer ultrasonography as the first modality of imaging. If some informations are not given by ultrasonography, then we can go for mammography. So less than 35 years, ultrasonography is the imaging of choice, and more than 35 years, mammography is the imaging of choice. Next comes a biopsy. Preferably, it is an excisional biopsy nowadays. Preferably, it is a non-excisional biopsy. The role of excisional biopsy has gone, and the biopsy should preferably be a core biopsy. It is also called true cut biopsy, because the advantage with core biopsy is this, that it takes a tissue also. So we do it under ultrasound guidance and in local anesthesia. So it gives more information. And the fine needle aspiration biopsy is one of the method, but it is not that accurate. So it has been completely replaced by core biopsy. And the test is so good that it has been seen that when all the modalities, imaging, biopsy, and clinical examination are negative, then the chances of having a breast cancer is less than 1%. And if they are positive, then the chances of having a breast cancer is 96%. So triple test is the test for diagnosing a breast lump and to prove that it is cancerous or not. Thank you so much.
Thank you so much, ma'am. Very well said. We move on to our next expert, Dr. Mrinalini Mani, ma'am. Ma'am, please unmute yourself first. You're muted.
Yeah, I'm sorry. Good evening, everyone. So reaching the fag end of the program, and a lot of have been spoken about breast cancers. I am to speak on a slightly different topic today, fertility preservation in breast cancers. We keep on talking of, as Dr. Leena also said, alarming increase in the rate of cancers in our country, especially in the urban. And thankfully, as the previous speakers mentioned, we have early diagnosis these days and have beautiful treatment modalities available, and the survival has increased. The 5-year survival rate is on the rise. So then now we have to, as a gynecologist, we have to think about her fertility. What happens? Initially, it was a myth, or I should say a dictum. A cancer diagnosed patient just talk about surviving. The issue was survival. Now we moved a step ahead and we are talking about her fertility preservation. So what we have to see, and as the graph was shown by one of the previous speakers, that in India, we are getting a peak at a younger age group, between 25 and 35 years. So this is the age when we need to concern about the fertility, and most of these women can be unmarried as well. And as we all know, these all will be taking radiotherapy and chemotherapy later on, and these have and ovaries are chemosensitive, and there will be ovarian follicle burnout will be there. So the lot of this goes into the decision making, and we need to bring in oncofertility now. So I think every tumor board should have a gynecologist on board. And some of the corporate hospitals, I'm very glad to know, are regularly calling the gynecologists in the tumor boards these days. We have to think, what are the opportunities available? What the patient wants? What is the choice? Does she want preservation or not? And the future childbearing potential. So which patient to offer fertility preservation? There are various criteria. I'm just be enlightening few of them. She should be preferably less than 35 years of age, should not have received previous chemo or radiotherapy after 15 years of age. And what is the realistic 5-year survival of this patient at the time of diagnosis? Otherwise, the whole point is futile going into such expensive procedures. And what is the risk of premature ovarian failure in such patients? And definitely, there should be informed consent by the lady. And the timing of fertility preservation, when should we talk about it? Ideally, yes, at the time of diagnosis, we should give her the options. So and what are the modalities available to us? We have some time-tested modalities with us for preservation, like we have embryo preservation for IVF. So ESMO in 2020 came out with guidelines for such patients. And if we preserve the fertility before treatment, and we have a window of 2-week delay before the start of the therapy, we can do ovarian stimulation, and we can do IVF embryo cryopreservation, and also offer mature oocyte vitrification can be done. But most of the times, because of the late diagnosis, unfortunately in our country, in most of the centers, and urgent fertility preservation is required. We don't have this 2 weeks gap. So what do we do then? We can always go in for random IVF protocol and do cryopreservation of the embryos. And also we can offer her oocyte cryopreservation. And ovarian tissue cryopreservation can also be offered. Like we have been preserving embryos since time immemorial in our country now with a lot of IVF centers. Oocyte preservation is slightly expensive and not available everywhere. And particularly the unmarried like to summarize by saying that no study till date have shown an increased risk of breast cancer recurrence in women who want to become pregnant and who have become pregnant after completing breast cancer treatment, regardless of the time since the cancer diagnosis. And also, no studies have shown any adverse cancer effects from ovarian stimulation before treatment or from ovarian function suppression during the chemotherapy. So these are the options available. Yeah, thank you very much.
Very well said, ma'am. Thank you, ma'am. And with the rising incidence of breast cancer, and especially occurring in younger age group where they have not completed their families and they want to preserve their fertility or fertility preservation therapy should be offered to them. Then there will always be a delay of 2 to 3 weeks by the time the ovaries are stimulated and the oocytes are retrieved and cryopreserved oocytes or the embryo. So, Dr. Sir, I want to ask whether this 2 to 3 weeks delay, whether it will be affecting the prognosis of the patient?
Normally, nowadays, I think with this rapid cycle available.
I think there's some transmission issues. Dr. Vaishali?
Yeah, so obviously a 2 to 3 week delay would be detrimental in especially young ladies who have triple negative or rapidly progressing type of cancers. So there is always a question, because these are the young women who need that fertility preservation option, and in these patients they have this Sir, go ahead, please. We were not able to hear you.
Yes, sir.
Yeah. So basically, as I said, this 2 to 3 weeks of delay is not something which is harmful. We are happy if the patient is keen on fertility sparing and is suitable for it. They should go ahead with oocyte harvesting and either oocyte cryopreservation or embryo cryopreservation.
I think we are on the public platform. It is very important for me to tell that even if the embryo are preserved in, the embryos are preserved if they are good quality, and we find that the retrieval rate is around 80%. If we are doing the preservation of the oocytes, they must be very, very properly counseled. It should be recorded counseling that the retrieval rate is not more than 60%. So this particular message must go with them. Yeah. And they already have the ovarian reserve on the lower side. So that part also need to be told to them that, how much are we going to retrieve and things like that. But what I feel is that legally it is very important that before she goes for treatment, she must be counseled. There is something like this is available.
Yes. And I would like to add one more point here, ma'am, to carry this forward, the legal point. Unfortunately, in our country, rather in most of the parts of the world, fertility preservation is not covered by insurance companies as yet. So this issue has to be taken up, because now since we have a lot of more and more patients coming for preservation of their fertility, this has to be taken up. Yeah.
See, the question is that here I am trying to tell you, I'm talking about something like about 12, 13 years back. This concept of fertility was just not there. Yes. At least now there is a term like this. So what I'm trying to say from the medical legal point of view, even if you're taking for the treatment, Vaishali says that, younger patient 2 weeks are very critical. And in that particular patient, it must be documented that a counseling was done for her. It is for her to decide what she wants.
Precisely, true.
Just to continue with that, in our hospital, our onco team, they get in touch with us and the patients are coming to us and they are being counseled by us also. And we have also done fertility preservation in 2 or 3 patients.
That's really good. That's very encouraging, ma'am. And can we have inputs from Dr. Uma, ma'am? Dr. Uma Vaidyanathan, please unmute yourself.
Yeah, hi. It was a very enlightening discussion so far, and I've been asked to sort of speak about the psychological aspects in breast cancer patients. Now, I was fortunate enough a few years back to be a part of a seminar in person where I had a word with around 60 breast cancer survivors, and the topic of the seminar was sexuality in breast cancer patients. Now, when I started reading, I realized that there are so many aspects with respect to breast cancer treatment that we probably do not even cover. They are just patients to us, but they are also women. They are women with families, with children, with partners. I recall when I spoke to those women, the talk was more about, the fact that when they would undergo chemotherapy, radiotherapy, when they would undergo surgery, they would undergo steroid treatment, they would have these huge hormonal surges because of which they would go home and they would actually want to have sex, but their partners would just not touch them. Either because of feeling that, she's not well, ये ठीक नहीं है, ये अभी आई है, पता नहीं ऐसे क्यों कर रही है, behavioral changes, the partners not perceiving them the way they were before starting treatment, their children not looking at them in the same way, loss of income at times because of prolonged treatment due to breast cancer, the families undergo so much of stress and strain. I realized that, we probably are not even talking about these issues, and we're not even counseling them that these things may arise. There can be a loss of fertility, like now we are talking about fertility preservation, but many a times this may not be covered during their counseling. So it's very important, as Dr. Sharda said, that it has to be documented. We have to talk to them about these issues as well, that it is going to impact your sex life, it is going to impact your relationship with your partner, it is going to impact your relationship with your family and your children. You're not going to be the head of the house as you were. You may not be as vital and active as before. It will take some time for you to come back to normal. So all these things, when we talk to a patient of breast cancer, especially the breast cancer survivors, we really need to cover and counsel them on these aspects. Thank you.
Thank you, Dr. Uma. Really good to hear about this aspect as well in the breast cancer treatment, and this is very, very important. Can we have inputs from
Dr. Arun? We will wind up after that.
Dr. Poonam, ma'am. Would you like to?
Yes, ultrasound in breast cancer, I think that has already been covered. But most important thing is that I think all the gynecologists who are doing their ultrasounds, at least they should learn breast ultrasound also, because it is very simple. At least you can see the lump and you can just see the vascularity, and at proper time then you can refer the patient to the concerned person.
Thank you, ma'am.
Over to you, Dr. Goyal, Doctor.
First of all, big thank you to Dr. Sharda Jain ma'am and Dr. Meenakshi ma'am for really putting the effort to get this meeting. And I must say that it's not the total number of people who were there. What I see is that it is the leaders of the Delhi Gynecology Forum who are here, and they would really pass on the message to their colleagues and to the coming generation. So it is a message which is going to spread through all of you, and you are going to become our messengers. So that is what I see coming out of this. And as I mentioned previously also, the responses we have had in poll questions have really been hearteningly very positive. The messages have gone across very well. I would just say what Dr. Poonam said about ultrasound. Okay, learning a little bit about ultrasound is good, but as a rule, what I would say is that a systematic training in breast ultrasound would be important, because even for the radiologists, we say nowadays that people who do breast radiology need to focus on breast radiology. That is why how they can do a better job. Not every radiologist would be able to do justice to this field. The field has developed a lot. It has become very complex. And the thing is that the decision making is very critical. The impact of one wrong decision can be quite bad. And globally in US and Europe, we know that litigations, medico-legal litigations, breast imaging is one of the commonest subjects of litigation. So we have to be very cautious about this. With that, thanks once again. And I would request Dr. Meenakshi and Dr. Sharda Jain ma'am to close the.
I think it was a wonderful session. And as you rightly said, that, this time we have the proposed breast committee chairperson, and the members are here, and the message was right for them, that they should go home with the very clear messages that whenever there is a lump, irrespective of the age, one should think about breast carcinoma. And second thing is that it is three things need to be done, which as Dr. Vaishali had pointed out. And thirdly, lastly, the message should be very clear. You should be sure before you reassure.
Thank you, ma'am. And I sincerely thanks Dr. Arun Goel, sir, and Dr. Vaishali for putting the efforts of bringing such an enriching webinar to all of us. And I sincerely thank all the experts.
I could see that as 60 people joined. It's a big number. It's a big number.
Thank you.
Yes, I mean, all the experts who have really put in their expert comments, and really it has opened up new topics which need to be dealt with in detail in the future webinars. I think especially the breast fertility conserving treatment, and as well as the psychological aspects and the diagnosis. And with this webinar, I think everyone is very well clear that the coordinated biopsy should be the diagnosis of choice. FNAC should be done away with, and we should be sure before we reassure that the patient does not have a breast cancer. All breast lumps, especially in the age group of more than 50, should be taken as cancer until and unless they are proved otherwise. And we should not hesitate in referring these patients to the breast cancer team for evaluation whenever there is a suspicion of a malignancy. So with this, I close this webinar, and I sincerely thank everyone who have joined, all the delegates or the participants who have joined listening to us. I think everyone has become wiser today. Thank you.
Thank you.
Thank you.
Thank you, sir.
Thank you.
Thank you, ma'am.
Thank you, ma'am.